Hi, everyone. Welcome. My name is Dr. Jack West. I'm a medical oncologist at Swedish Cancer Institute and the founder and CEO of GRACE, Global Resource for Advancing Cancer Education. And I'm very happy to welcome folks here today for our webinar with Dr. Dara Aisner on the topic of what is pathology and especially molecular pathology, which is a very timely topic that we are discussing all the time on the website and at our research meetings, because more and more of our new treatments are being driven by findings from people like Dr. Aisner, and she's really one of the leaders at the forefront working at the University of Colorado Molecular Correlates Laboratory. And so I was very happy to have Dr. Aisner join us today to go over really some of the basics of what she does and where things are going in the field. I'll mention that this program is co-sponsored by GRACE along with the Longevity Foundation. So with that, I'd like to welcome Dr. Aisner, and I will let her just talk about a few general topics. Can you start by explaining the basics of what pathology is? Really, how does a biopsy procedure get converted into the diagnosis that we use for guiding our own treatments?
Thank you so much, Jack, for inviting me, and I hope that today turns out to be helpful for some people to try to demystify this. I know it's very much a black box for a lot of people, that a procedure happens and a bunch of paperwork comes out, and it's not really clear what happens in between. I started off just by sort of trying to explain what a textbook definition of pathology is, and I mostly look at this as sort of the medical blah, blah, blah definition of pathology, which is not very helpful for most people in understanding what we actually do. So I think there's the what is pathology by definition, but then there is the what is pathology really. The way I tend to describe this for people is that anytime any tissue gets taken out of any body, it has to get sent to a pathologist for evaluation. And that's basically a universal truth with a very, very few number of exceptions. It's the pathologist's job to really take this tissue and characterize it to the best of their ability in terms of every possible spectrum of characterization, normal versus abnormal. And if it's abnormal, there's lots of different categories we try to think about when we categorize a piece of tissue. Certainly in this day and age, one of the pathologist's main job is to ask the question of whether something is cancerous or non-cancerous. And I would say that probably about 70 to 80% of what we do is driven from the question of this seems abnormal clinically, is it cancer? Once we've arrived at that decision that something is abnormal or even cancer, it's our job to further classify it into discrete groups. And that is all very much driven behind the idea that putting things into discrete groups helps with treatment. So within the realm of cancer, not only knowing that something is cancer, but what specific type of cancer, what organ it came from, even within the organ, there are lots of smaller distinctions that we make can help to drive therapy. And similarly, an example I included here is if we decide, based on looking at something that is infectious, being able to identify what type of infection obviously helps with treatment. In terms of cancer, one of our main jobs is to do what we call grading and staging, and that is to basically assess the cancer for its severity in terms of how aggressive the tumor looks and behaves on a local level within the tissue itself, and that's grading. And staging is really the much larger question of how far has the cancer spread. So I do like to try to explain these things graphically because I think it makes a lot more sense. This is still kind of black box material. So a specimen arrives in pathology, and the first thing we do is we do what's called a gross evaluation. We basically describe everything we can about the specimen, the size, the type, what does it look like, does it look abnormal, and then we cut it into small pieces to allow that microscopic evaluation. And we get to that final step of microscopic evaluation first by putting things into a fixative, and that's most commonly formalin. This step of gross evaluation, where if it's a large specimen, we will cut it into small pieces. I'll go ahead and give you the warning now. There's a running joke that pathologists like to describe everything in terms of food. And so we describe cutting a specimen up as bread loafing it. And I think that's a good mental image of how we actually treat a specimen. We take it and we basically, from one end to the other, cut it into slices with the aim of trying to look at each individual slice to see if it looks normal or abnormal. So there's my food analogy number one. And food analogy number two is this process of putting things into formalin is sort of like pickling things, and it's a form of long-term preserving things to hold tissue in place in time so we can look at it at any time later. So after we've done this initial evaluation, we do what's called processing the specimen, and this is a series of chemical exposures. And if anybody has ever gone to see the exhibit Bodies or Bodies in Motion or any of the various Bodies exhibit, it's a very similar process, and it's sort of like a plastinization. And what it does is at the very end, it allows us to take something that came in as tissue, which is usually very soft and hard to cut, and it turns it into something that's much more similar to the consistency of plastic. And that allows us to then manipulate the specimen in different ways. And so what we do next is we embed it in a mold of paraffin wax. And this allows us to cut the specimen into very thin slices. And so we cut the specimen into very thin slices and put it onto glass slides. And a lot of us can make the analogy that this is like a deli slicer on a very, very small scale. And then the glass slides are stained so we can see different features of the tissue. And I've gone ahead and described this pictorially as well, so you can actually see it. This is where the specimen comes in and is cut into small pieces. It goes into these specially designed pieces of plastic that allow those chemical steps to infiltrate the tissue to create that plastinization-like process. This is the fixation and the processing through this fancy piece of equipment that basically exchanges chemical step after chemical step to undertake that plastinization. And this is tissue embedding in paraffin. And the net result of embedding a tissue in paraffin is this thing we call a block. And for many patients, when their physician says, we've asked the pathologist to pull the block or we've asked for the block to be sent, this is what they're referring to. They're referring to the actual piece of tissue that has been embedded in something that allows it to have an archival quality. And so that way it can be shipped at room temperature, it can be moved around, we can go back to it time and time again until that piece of tissue has been cut through. This is an image of what that small-scale deli slicer looks like, and this is what it looks like to actually cut off of a paraffin block and put the tissue onto slides. We do this on a water bath so we get a nice, flat, even surface. And then we stain the tissue, we cover slip the slide, and then we can look at it under the microscope. So the last thing I'll say about this, which I alluded to before, is that all of this is very much driven by what the end goal of the question is, which is how does getting this information help with determining treatment? In many regards, across the board, when people look at how to treat cancer, the type of cancer and the stage of cancer are considered two of the most key pieces of information to know before you can undertake a treatment plan. So the type and grade is something I alluded to before, and we can often determine cancer type and cancer grade with small biopsy specimens, FNAs, pleural fluids are things that we can use to determine this basic piece of information. And sometimes we use additional stains to help us do that. But another large piece of information is influenced by stage, and that's really describing the extent or spread of the disease. And it's really something that's very different from every organ to every organ. So how we define spread in lung cancer is different from how we define spread in bladder cancer. And this is something that's been defined by very rigorous studies over a long period of time. Now, obviously, in order to do this, we have to be able to get a piece of tissue out that allows us to determine stage. And in a lot of cases, and especially in lung cancer, that doesn't happen, where a surgery that takes out that initial lesion doesn't happen. And so the staging can be approximated using a number of clinical techniques, most notably imaging. And so even though pathology is considered the gold standard for determining stage, the ability to come at a treatment decision is something that can be done very commonly by using clinical techniques like imaging.
So we've also been talking about this new concept of molecular pathology and molecular oncology. So what is that, and how is that an evolution of what you've been talking about?
So what I've really been talking about here is something that is a very classic approach to diagnosis. I would say that in its fundamental ways, it's changed very, very little over many decades. And the idea that we take tissue and we look at it and we put it on slides to evaluate it is something that's an old concept that's been happening for a long time. Molecular pathology is a very new concept, and the idea here is that we look at the genes and changes in genes in individual patient tumor cells to try to achieve a number of specific goals. For the purposes of lung cancer, I think the most salient thing is that we use this to try to predict response to therapy, but we can also use molecular testing in some disease settings to try to help with the diagnosis or predict the disease course. This is something that I think is really a forefront of how pathology is going to change in terms of what are the things that we considered the standard things to do. So not only is it going to be standard to look at tissue, but looking at the genes and the changes in genes in individual tumor cells, I think is going to increasingly become a standard thing to do. Now, as a molecular pathologist, well, I look at genes and gene changes in individual tumor cells. How does that work, and what's different about that? The first thing I'll say is that the number one goal for me as a lab director is to maintain a very high-quality laboratory, and this is achieved through a number of things. What I'm showing here is a pictorial of one specific step, but the idea here is that there is no such thing as a perfect test. And it's part of my job to try to make sure that the methods I use for a test give me the least possibility of a false negative or a false positive result. So some of the ways we go about this in terms of molecular pathology is that in some cases for some test types, we actually pull individual tumor cells off from tissue. This is a picture of this being done in our laboratory here. And we can take those individual tumor cells that have been plucked off the slide and extract DNA or RNA or any number of other things out of those tumor cells. This is usually geared around testing that is designed to look for changes that are present only in the tumor cells and not in the surrounding cells. The other thing we can do that's not depicted in this image here is that we can actually evaluate tumor cells while they are still on the slide for changes in DNA. And the main method you might hear about for that is called FISH. There's some analogous methods called FISH, but the idea here is that we perform an assay that's called in situ, and it's called in situ because the testing is actually done while the cells are still retaining their relationships to each other on the slide. As I mentioned, there is no such thing as a perfect test. All tests have their own limitations, and part of my job, as I said, is not only to minimize the likelihood of a false positive or false negative, it's also to understand all of the parameters and all the limitations of a test so that way I can best understand what specimen is appropriate to use and what result that comes out is trustworthy. And I think that there are a couple of important details of a molecular test that are things that are good for people to understand. And the first of these are two related concepts called clinical and analytical sensitivity. And the first of these, which is clinical sensitivity, is the question of what does the test look for? And so this is really the concept of you only get the answers to the questions you ask. So if, for example, EGFR has a lot of possible mutations in it, if a test only asks the question, is mutation number 1 or mutation number 2 present, you're not going to get the answer to anything other than those two questions. And so that's a concept that we refer to as clinical sensitivity. And it's important to realize that not every lab uses a test that's going to detect every possible change. And the reason for that has to do with the opposite parameter that I'm talking about here, which is analytical sensitivity, which is really a question of how sensitively does the test look for these changes. This is really the needle in a haystack question. This is really the question of if you have a big stack of hay and you're looking for one needle in it, how well does your test identify that one needle behind all the visual disturbance of pieces of hay? In this analogy, the tumor cells are the needles and all of the rest of the specimen is the haystack. And it's important to realize that any specimen that comes to a pathologist that has a diagnosis of a cancer in it is not 100% cancer cells in the specimen. In some cases, we can issue a diagnosis of cancer, but there may only be 1% cancer cells in there. So if your assay is not a very good needle in the haystack detector, a sample that has only 1% tumor cells may not do the trick between combining that sample with that assay. So the issue here really is combining these two parameters to be able to understand how a test works. And this is an example of a slide where I'm not going to try to belabor the point with all the text, but it's to sort of demonstrate the idea that these are two related but balanced concepts. The clinical sensitivity of you only get the answers to the question you ask versus how sensitively can you ask that question. And so each of these things that are inherent to a test have potential sources of false negative. And so, like I indicated, a false negative that's related to the clinical sensitivity of a test is because the test didn't ask that question. And a false negative related to the analytic sensitivity of a test is because the test is not designed to pick only one needle out of a haystack. It might need 30 needles in the haystack in order for it to work. So you could ask the question in that case, well, if you have these tests that can detect just one needle in this big haystack, why wouldn't you always just use that kind of test? And the answer is that these things are usually inversely related. So a test that has really substantially improved analytic sensitivity usually does not have great clinical sensitivity. It's going to be highly targeted and only ask one or two questions, and vice versa.
Well, I would imagine also that one of the issues is that sometimes if you're casting such a wide net, you might pick up mutations that we're not sure of the significance of, that we know, for instance, that a couple of EGFR mutations are well associated with activity, but others that are rare enough that we're not sure if they should be bunched in the same category. So I would imagine that it's a question of the more sensitive you are, you might pick up some stuff that could end up being noise rather than real signal.
Well, typically the tests that have really great analytic sensitivity are targeted mostly to the things that are known to be relevant. So it's uncommon right now with the technology that's commonly adopted now for that to be an issue. But it is not uncommon to find an alteration where the clinical significance of that alteration isn't well defined. And there are a lot of ways that we go about trying to help identify what that significance is. But at the end of the day, if I identify a mutation in a patient's tumor sample and I go through all of the resources I have and it turns out that's only been described 5 other times, then it doesn't matter how much I'm able to put my head together with other people. If there are only 5 experiences to go on, then that's not a lot to go on.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support.